Thank you for joining us for a Mayo Clinic NeuroChat. Today, Dr. Ben Brown and Dr. James Meskia will discuss carotid artery disease. We'll take questions from our viewers on Facebook, as well as Mayo Clinic Connect, near the end of the broadcast. Let's start off by learning a little about each of you. Dr. Brown?
Sure. My name is Ben Brown. I'm a neurosurgeon at Mayo Clinic in Florida. I specialize in cerebrovascular disorders and the surgical treatment of those things. Those disorders would include cerebral aneurysms, arteriovenous malformations, carotid disease in the neck, narrowing of blood vessels in the brain, cavernous malformations, and things like that. What got me interested in neurosurgery to begin with, I went through electrical engineering in college. Medicine was not my first thought, but as I went through that, I thought, I did some rotations actually with family friends who are physicians, and got really interested in medical disorders, and got to scrub in on some surgeries, and was really taken by the amount of trust that's put in a surgeon, the ability to go in and positively affect someone's medical health by physically changing their anatomy. And the electrical engineering side of me, I think, sort of had me gravitate towards sort of the wiring of the brain, and it just kind of fit together, and that's how I sort of found myself in this path.
And my name is James Meskia. I'm chair of the Department of Neurology here at Mayo Clinic, Florida. I've been a specialist in vascular neurology for many years now. What got me interested in the field of vascular neurology was when I was in training as a resident. Tissue plasminogen activator was first coming on the scene, and it was the first proven therapy for acute stroke. So I got to see the change in how we approach stroke as a disease from sort of a nihilistic perspective, where we were not able to perform anything in particular that would reduce the size of the deficit or the size of the stroke, to where it became a medical emergency and we could effect a positive change. That was exciting to me.
Thank you. If you're just tuning in, we're with Dr. Ben Brown and Dr. James Meskia for a Mayo Clinic NeuroChat on carotid artery disease. First off, can you explain what exactly carotid artery disease is?
Sure. Carotid artery disease, broadly speaking, refers to some pathology or something wrong with the major blood vessels of the front part of the brain. They course up through the neck and supply about 80% of the blood supply to the brain. What's most often referred to when people say carotid disease is atherosclerotic disease, or plaque buildup in the wall of the artery, which leads to the artery becoming more and more narrow, and that plaque becomes more and more unstable and can actually cause a crack on the inner lining of the blood vessel that then causes blood clots to form that can then go up to the brain and cause a significant stroke. Other things like a dissection of the carotid artery, which we may talk about later, that can be caused by trauma, and some other general things, but for the most part, atherosclerotic disease.
So who's at risk?
Go ahead, Dr. Meskia.
Yeah, thanks. Well, we're all at some basic risk of developing plaque in the carotid arteries. But generally, the vascular risk factors that have been associated with coronary artery disease or heart attack are also associated with carotid disease. So, for example, high blood pressure or hypertension, diabetes mellitus, cigarette smoking, excessive fat in the diet. These sorts of things are associated with carotid disease. Probably the single most important risk factor to gain control of is hypertension, but clearly cigarette smoking plays a role.
Thank you. Is a procedure the only way to treat carotid artery disease, or can medications be used for treatment?
Well, what I would say about that is that it's a very important question that you address. But I prefer to look at it as a combination approach of medicine and surgery rather than an either-or approach. Many patients are best served by both a surgical approach to address the plaque buildup in that particular part of the body, in combination with a medical approach that recognizes that atherosclerosis is a systemic process triggered by inflammation and fueled by certain risk factors, and addressing it that way.
And if I could add something there, I totally agree. You know, it can be tempting to look at a surgical procedure and feel like that's going to cure you of this problem or something like that, but it's very important in a condition like, you know, a carotid disease to understand that there's sort of an underlying substrate happening or underlying problem, and even if the problem is addressed surgically, it's possible for it to reoccur, it's possible for it to happen in other blood vessels. And so really anyone who's having surgery, you know, has to have excellent medical care associated with that, in my opinion.
Thank you, Dr. Brown. What are the surgical techniques for opening a carotid artery?
Sure, so there's two main types. The classic procedure is what's called a carotid endarterectomy, which is a traditional surgery where an incision is made on the front of the neck. We go down between the muscle that's used to turn the head and the windpipe and find the carotid artery. The plaque is generally sort of right at a common location where the carotid artery splits. We locate that blockage and clamp the artery and make an incision on the artery itself to open it up and go in and scoop out the plaque that's inside. Once the plaque is removed, we either sew the artery back directly or sometimes add a patch on the artery to kind of expand it and then restore flow to the blood vessel. The other technique, which is more recent, is to go in from the leg and the femoral artery and go all the way up through the body with catheters to the place where the carotid is blocked, and then use a stent and perhaps a balloon as well to open up that narrowing, and then use the stent to keep it open.
Which surgical technique is best, an endarterectomy or a stent?
Sure. So endarterectomy, again, is the classic procedure. It's the mainstay of treatment. Recently, in 2010, Mayo Clinic did a study that compared endarterectomy with carotid stenting. In that trial, endarterectomy had a lower risk of stroke in the time right around the procedure than did carotid stenting. That being said, it also had a higher risk of heart attack. So there were complications on both sides, but since stroke was the main thing we were trying to avoid, we still feel like endarterectomy has the slight edge. That being said, there are patients that have perhaps a blocked artery on the other side that can make surgery more risky. If they've already had surgery on that carotid artery, it can be harder to access the artery. If they've had radiation in the neck, if the blockage in their carotid artery is way up high behind the jaw, it can be very hard to get to the artery and a little more risky. And some patients have they have issues with their heart and lungs and may have trouble with general anesthesia. In those patients, we tend to prefer carotid stenting because the risk of the endarterectomy is likely increased if those factors are present.
Thank you. We have a question from a Mayo Clinic Connect member who asks if you could mention common symptoms patients may experience with a carotid dissection and fibromuscular dysplasia, or FMD.
Okay. Well, on the issue of what kind of symptoms you might experience with carotid dissection, I think they fall into generally two groups, if you will. One is the group of symptoms that is common to all stroke, and that would be sudden weakness or numbness of the arm or leg, sudden difficulty with speech, language, vision in one eye, those sorts of symptoms that you could get from any warning sign of stroke. They're commonly available through the American Heart Association and other organizations, lists of symptoms that patients should be aware of so that they can recognize stroke symptoms and respond accordingly. In addition, though, in the case of dissection, patients can experience pain related to the tear in the lining of the artery. That pain typically occurs in the lateral aspect of the neck and can radiate up into the jaw and ear. And that, in combination with warning signs of stroke, often points to a carotid dissection. Now, the issue of fibromuscular dysplasia is an important one. It's tricky in that, in general, the arteries don't create symptoms until or unless they dissect. So people can go for many years with fibromuscular dysplasia, and some patients all their lives, without actually experiencing stroke or other significant medical symptoms. However, if an FMD patient develops dissection, then they too may have the symptoms we talked about when we described with dissection.
Thank you, Dr. Meskia. A question from another Mayo Clinic Connect member is, I had a stroke in 2015 while I was doing some lightweight work. I felt it in my eyes and I couldn't move. I had a good recovery, but recently I had a very sharp pain in the back of my head to the center, which left me with neck and head pain and stiffness. Could this have been another stroke?
So, broadly speaking, a stroke means that oxygen has been deprived to a part of the brain and caused damage to the brain itself. That can be caused by blockage to an artery or from an artery breaking and having bleeding inside of the brain. Generally, those things are associated with a neurologic deficit because the brain is injured. The sudden onset of a headache is somewhat nonspecific, but and may not have been a stroke, probably was not a stroke, but any new headache that comes around that is something different than you've experienced before, or something that is kind of happening more frequently, is probably warranted to be checked out by a physician just to make sure there's nothing more concerning going on. And there is one form of stroke that's classically associated with headache where there's the sudden onset of the worst headache of your life. That's classic for a bleeding aneurysm in the brain. And so certainly in that situation it would be important to call 911 and get medical help immediately.
Thank you. This same member had two follow-up questions. What is considered young stroke? And what do white matter changes on an MRI mean?
So the term young stroke has been applied differently in the medical literature. Typically, you'll see less than 50 years of age, or a stroke beginning less than 45 years of age to be classified as young stroke. Because, for example, in this country, the median age of stroke is roughly 70 years. So when patients fall into this group of young stroke, they often have stroke related to something other than atherosclerotic disease, such as plaque buildup in the carotid artery. It may be related to carotid dissection or an inherited disorder or a disorder of blood coagulation, but it's generally clinically relevant to kind of consider young stroke a little bit more broadly in terms of its mechanism than older stroke or more typical stroke. Oh, and on the issue of white matter changes, white matter disease, first of all, the terminology can confuse patients, no doubt. It's applied differently by different physicians, and the same condition is described as white matter disease or white matter hyperintensities or nonspecific white matter changes, etc. And so all these sort of terms that refer to what is seen on an MRI in the white matter create some confusion. It's common as people get older to have increasing amounts of spots in the white matter seen on MRI. And these hyperintensities, because they appear bright on MRI, are generally attributed to what we call small vessel disease, so that the blood vessels in the brain, the small blood vessels in the brain that supply deep areas of the brain are not quite working as they used to, supplying blood at the rate that the brain requires, and so you can see these changes. In the early stages of white matter ischemic disease, generally it's clinically silent, meaning that patients don't really recognize anything as being wrong, and neither do their employers, their family members, etc. However, if it becomes severe, it can affect thinking to the point where it slows down thinking, what we call executive processing, so planning, emotional control, and things of that nature. So it's not trivial. It should be seen as a marker of small vessel disease, and risk factors should be reviewed with your doctor to see that you're getting proper care of blood pressure and lipids and all the rest.
Thank you. We have another question from a Mayo Clinic Connect member. What is the best kind of doctor to diagnose carotid artery disease? I've been told I have mild to moderate plaque in my carotid artery.
So in general, I would say there's no one best type of physician to diagnose carotid artery disease. It's a very prevalent disease within our society, and can be picked up sometimes on a basic neurologic exam. So if you're having a routine physical with your primary care physician, they may listen to the side of your neck. They may hear something called a bruit, which is when the blood flow speeds up as it passes by that blockage, much like the water speeds up when you hold your finger over a hose, and that has a characteristic sound that can be heard with a stethoscope. So that's one way that it can be diagnosed. If your physician suspects that you may have carotid disease, they may order some type of imaging as well, which comes in various forms like an ultrasound or a CT or MRI scan. I would say while no one type of physician is the best to detect one, I would say probably the most are detected by primary care physicians or neurologists. That being said, a wide variety of physicians treat carotid disease and are able to pick it up.
Thank you, Dr. Brown. Another question from Mayo Clinic Connect is, should I be concerned that I could have a stroke since I've had a mesenteric dissection twice?
Well, I think it's reasonable to have a heightened sense of awareness about the possibility of stroke if you've had a medical history of mesenteric artery dissection. The concept here being that there may be some underlying connective tissue disorder that's causing weakness in the lining of the blood vessels, much like fibromuscular dysplasia and other conditions. So I would say that it's wise to be aware of the potential for the heightened potential for a stroke. And this really comes back to the concept of brain attack. If you feel you're having symptoms of a stroke, it's a 911 medical emergency, because only with proper evaluation and imaging could you be offered potentially life-saving and brain-saving procedures. Also, you should be familiar with the warning signs of stroke, as I had spoken about earlier. Anything that's sudden and takes away a function, particularly if it's on one side of the body, such as weakness or numbness of the arms and legs. This should be considered stroke until proven otherwise, and immediate medical treatment should be instituted. As for whether you should have anything done in terms of surveillance imaging, say ultrasound and so forth, to see if you're having dissection of carotid arteries, I would say in general the answer would be no, because we don't have good imaging predictors as to people at such high risk of dissection that they should have things like stenting.
Thank you. We have a question from a Facebook Live viewer who asks if carotid disease affects patients' emotional or mental well-being, maybe with anger or aggression.
Well, I would say that independent of a stroke that might have come from plaque in the carotid arteries, it's actually a topic of considerable research to see if chronic decreased blood flow on one side of the brain could lead to cognitive and or emotional symptoms. So it's not impossible to attribute some symptoms to so-called chronic ischemia, although typically we would not think that carotid disease would be high on the list as a cause of those symptoms.
Thank you. And our last question from a Facebook viewer: can quadruple bypass increase the chances of carotid disease later on?
Well, to my knowledge, the simple fact of having a quadruple bypass would not increase the risk of having carotid disease. But because the patient had a quadruple bypass suggests that they have extensive cardiovascular disease. And as Dr. Meschia spoke about earlier, the risk factors for stroke and cardiovascular disease have a great amount of overlap. So people who have heart disease often have disease in their leg blood vessels or disease in their neck blood vessels, and need to be followed closely by their medical provider, either a primary care physician or a neurologist, to make sure that those risk factors are monitored closely. Dr. Meschia, you have anything to add?
Yeah, I agree with what's been said. I think that atherosclerotic disease in one arterial bed, be it the heart or the legs, the kidneys or what have you, should generally be seen as a risk factor for having carotid disease as well. Typically, it's more common to have carotid disease associated with disease involving the arteries to the legs than the heart. But the actual act of doing the surgery on the heart and doing the bypass on the heart should not increase the risk of subsequent carotid disease.
Thank you. That's all the time we have for today. Again, thank you for joining us for a Mayo Clinic Neuro Chat with Dr. Ben Brown and Dr. James Meschia. To learn and to receive email reminders of future broadcasts, please visit Mayo Clinic Connect at connect.mayoclinic.org.